So I'm going to talk about the new horizon in autoimmune POTS, as the POTS is the main subject of this meeting. You may know or may not know that. So that's why they invited me here. So to start with, this is obligatory, of course, and I'm sorry. It's not that easy. Now, just I'm going to talk about POTS and the autoimmune hypothesis of POTS. And I want to cover some of other findings supporting this idea and some of our findings, our own findings. And I will tell you about what's on the horizon, future perspective for the research, future research areas in this aspect. So as you can see here in this nice summary, you see the lady with puzzle building, forming her face, and you can see it's difficult to see the whole until the whole picture is on place. All puzzles are on place. So these are typical POTS patients. They have many symptoms. The spectrum is very wide, from cardiovascular symptoms through neuromuscular symptoms, and then gastrointestinal symptoms, chronic fatigue, and so on, pain in different locations, of course. But what is pathognomonic is this abnormal, very dramatic heart rate increase on standing. So, which is a sort of main sign of the syndrome. This is how we found it. And the wide spectrum of these different symptoms made us believe that it cannot be just one isolated problem to the heart, to the cardiovascular system, but it can be like with other autoimmune diseases, wide spectrum with one symptom which is predominant, the heart, tachycardia. So with this in mind, with this idea, this prerequisite in mind, so we just take a look at the definition of autoimmune disease, and this comes from Merriam-Webster dictionary. So you have to have something acting through your B cells or T cells on your own structures, on your own organism. So organism producing autoantibodies or giving weapon to T cells to destroy body's own structures. So this is definition. And if you look at I know maybe some of you are very familiar with the immune system, but I just made it just to go through the basics to make it all for us more familiar when we're going to talk about different objects, different targets, and different autoantibodies. So if you look here, you can see this innate immune system, which is the old one, and the new one, evolutionary new and adaptive immunity, using two weapons, using T cells attacking different, very specified targets, and autoantibodies, antibodies attacking specified objects. And we're going to focus, and we're going to talk about antibodies, or specifically autoantibodies, as a substrate for autoimmune disease, hypothetical autoimmune disease behind POTS. If you look at this diagram, and if you just move your attention to this one, what's important here is that something has to start the process. There must be some trigger setting this all in movement. And you may have viral infection, bacterial infection, you may have trauma, injury, and it starts the cascade activating T cells, or lymphocytes, T cells, and then B cells producing antibodies in excess, just as it needs, if appropriate, for a specific target. It starts with immunoglobulin M, and then immunoglobulin G, they take over. You can see the diagram on your left-hand side, right-hand side. So this is how it works. It's of course, needed to survive. So it's a system that makes us survive in our environment. But what about if the body recognizes something from its own structures as its enemy? It starts destroying it, fighting against it. This is how the autoimmune disease starts, more or less in a simplified manner. And now let's move our attention to POTS and the symptoms of POTS. You may have tachycardia, sinus tachycardia, venous pooling, and there were some hypotheses presented by different groups. We can group them into three main hypotheses. One hypothesis is about hyperadrenergic stimulation, norepinephrine spillover. Then we have this autoimmune hypothesis, autoimmune aggression against cardiovascular receptors, producing different effects, cardiovascular symptoms. And the third one, peripheral autonomic neuropathy, just making your body not responsive to volume shift in a proper way. So you don't have vasoconstriction, which is needed when you just change your body position. And in this case, sinus tachycardia would be compensatory, not in the first place. So our focus was mainly on the first group, autoantibodies against cardiac and vessel and vascular receptors, controlling the cardiovascular system in the whole. So, and if you look here, what receptors are we in mind? These receptors are called G protein-coupled receptors. You may have heard about them, but probably you may be surprised that they're very important for pharma industry. Nearly 50, some say 70% of all drugs for cardiovascular disease are targeting these receptors. You didn't know that? Yes, that's right. And this one is called beta adrenergic receptor. You see the ligand in the middle, just getting to the binding site and changing the structure and starting the cascade of different intracellular processes, like leading to depolarization, vasoconstriction, heart beating, and so on. So these are very important receptors. They control in an autonomic way many of the vital processes in our body. And just to make it more visible for you, just look at different G protein-coupled receptors, where they are situated in the body. They control pain, your bowel movements, your cardiovascular system. So you name it. You have one group here with receptors controlling sleep processes, controlling cardiovascular system, blood pressure control, and pain, and so on and so on. Hashimoto and thyroid gland function as well. These are the same receptors, the same main structure. So thinking about the symptoms in POTS, tachycardia, vasodilation, and just abnormal chaos in the cardiovascular system. So Professor David Kem, some years ago, started thinking about the idea of autoantibodies attacking the main cardiovascular receptors. And these autoantibodies would be directed against beta-1, beta-2, alpha-1 receptors with such effects like vasodilation, tachycardia, and so on. You can see the main three receptors of the cardiovascular system, which otherwise are controlled by sympathetic system. in a correct way. So overstimulation of this receptor would give you tachycardia, or blockade of this receptor would lead to vasodilation and so on. And what he did, what he looked at natural ligands, and you can see epinephrine here. This is just a simple molecule, very useful for the body. And this is not a very big molecule. If you compare epinephrine with a huge immunoglobulin G antibody, you can see the difference. Actually, the difference is even larger. It's like that. So it's almost 1,000 times larger. So antibodies almost 1,000 times larger than norepinephrine, small molecule. And now let's go to Star Wars a little bit, just to make it more understandable for you. I made this slide for you. You can see the Death Star, a huge molecule, immunoglobulin G, and small spacecraft from the rebels. Just like norepinephrine trying to get to the receptor, being blocked by the huge Death Stars. These are the real proportions. It's very useful to keep them in mind. And just to be more scientific, because we're talking about science, so we're moving from movie industry to science again. Oh, science is boring, some say. So, but if this is colorful, maybe as well as sort of fun. So you can see this colorful structure of the G protein coupled receptor seen from above, and 3 loops popping out, binding this small ligand in the middle. And then you have the Death Star coming here, blocking this receptor. You can understand why all these effects may be in place. So this huge molecule may change the structure of the receptor and produce both stimulating effects and blocking effects. Chaos in the end. So the ligand has no way to get into the binding site and start cascade of the different physiological processes in the cell. Now, with this in mind, let's move to David Kemp from Oklahoma City University, who checked this idea with cells with overexpressed different receptors on the surface. And he put immunoglobulins from POTS patients on the cells and checked what's going to happen. What happened was that they were overstimulated. They were stimulated by the plasma of POTS patients. Some of them, not all. Both beta-1, beta-2 receptor responded to it. And again, you may ask yourself where this assay comes from. The answer is from pharma industry. This is how they test their drugs that you prescribe or you use. They have the same cells with receptors. They put the drug and they check what's happening, adding the natural substance, epinephrine, or artificial synthesized like isoprenaline drugs, and testing how they respond when they are blocked by different antagonists. So he used the same assay, and he noticed that they were overstimulated by immunoglobulins from patients. So then we met a few years ago. We decided to perform this study. We sent him samples from Sweden. What we found with David was that most of POTS patients overstimulated alpha-1, beta-1, beta-2 receptors. They were just acting as if they were stimulated by natural ligand. And it was very nicely blocked on your right-hand side by antagonist, pharmacologically manufactured antagonist, prazosin and propranolol. Do you use propranolol? So he used that too, to block them. And we use propranolol in POTS. It's even better. Now you can see that it works. Actually, it's a good medicine. Don't use prazosin, by the way. It will make the things worse, of course. So then On your left-hand side, you can see that it creates even more chaos. Do you remember this huge molecule, immunoglobulin G, just lying down on the receptor, being blocked by the immunoglobulin? So you can see what's happening here. You need more adrenaline to produce vasoconstriction and less adrenaline to produce vasodilation. It's a perfect weapon. It's a real poison, all these autoantibodies. It can be blocked again. And again, when we can say, okay, these are the cells, this is just an assay, but he tested it on a rat cremaster artery, showing that the vessel get vasoconstrict, so get constricted under the action of immunoglobulins, and it can be blocked again by antagonist. So, okay, it's fine. So adrenergic receptors are influenced by, affected by immunoglobulins. Okay, but then he found out. Oh, this is blocked. He found out that there are other receptors, cardiovascular receptors, that may be affected by immunoglobulins. So we decided to test this hypothesis too. So we looked at angiotensin 2 type 1 receptor. Do you know what it does? Have you heard about convertase inhibitors? Do you use them for hypertension? Yeah, they are very popular actually. Now the problem is these receptors, which is a natural backup system for blood pressure control in the body, gets affected by immunoglobulins too. And guess what type of receptor it is? What do you think? Yeah, this is G protein coupled receptors as well. Oh, thank you. So again, the same story, another structure, but the effect is almost the same. And what's happening is they are overstimulated, but they block the natural effect of ligands, as you can see in this picture. Now, what we did in our study, in our smaller study, we took 47 POTS patients, 24 controls, and we used the same assay. And what we found here was that 4 types of different G protein coupled receptors, alpha 1, beta 2, muscarinic 2, and nociceptin receptor, which is responsible for pain experience in the body, all of them were overstimulated by immunoglobulins from the patient, POTS patients. You can see on your left-hand side in every diagram. Beta 2 were actually most impressively increased. And what can we do with this information? Probably we can look if we can have an assay that you can use to identify the patients, the real patients. Look at this receiver operating curve, characteristic curves here. Do you know what it is? How it came about? Have you heard about Battle of England and German planes coming to England trying to bomb London? And there was people sitting in an operator room and trying to hear what's coming, sitting like, let me just think a little bit. It's German. Let's destroy it. So the fighters were sent to destroy the German bombers. No, these are our boys coming back. Don't go and fight them. So they were just radiotelegraphists or sort of trained staff trying to recognize their own fighters and differentiate them from German ones. Oh, this is the curve. You higher the curves goes up, it's the better. So if you look here, you have area under curve for 4 different receptors, 0.9. It means that this operator would find, would identify 9 German bombers out of 10 coming. So he would make just 1 mistake. in 10 trials. It's really good. The same with the assay. It's really good to differentiate between cases and POTS patients. So the question is now, having all this knowledge, where do you go from here in this very troublesome syndrome? So I summarize it in these few sentences. We have to perform a head-to-head comparison of different assays, because there are different assays, ELISA assays, simpler methods, and the cell-based assays used by pharma industry, and even embryonic red cardiomyocytes that are used by one group in Berlin, Gerd Wallukat group. So we have to compare it head-to-head in a blinded way to see if the signal is the same, to make sure these are real autoantibodies in operation here. Then we have to perform this systematic characterization of immune system. Thank you. And see what's wrong. Is there some genetic difference, which is important, haplotype, that differ the POTS patients from the rest of the population? And it is very important to understand, to completely understand the etiology behind the syndrome. Actually, there are no syndromes. We create syndromes. There are only sick people which we try to characterize. So it's very important for you to keep in mind that we're not talking about syndromes floating above and just attacking poor people and just taking over. No, they are just sick people with symptoms, and we try to characterize them, giving them names. Oh, this is POTS patient, EDS, and chronic fatigue syndrome. They are sick people with different symptoms. So we have to characterize why these young girls, they got affected by these syndromes, by the set of the symptoms. And in the end, having this knowledge in hand, we have to test all of them and try different form of therapy to help them. And we're talking about different form of immunomodulation. It's a huge topic. I'm not going to cover it. I'm a cardiologist, so it wouldn't be fair if I would take over this subject as well. So I would just want to show you this diagram, the difference between ELISA, just epitopes, isolated epitopes, and the cell-based system on your right-hand, which reproduce what's happening in the body. So I think this right-hand diagram shows you the most accurate system, but it's very expensive, so we don't know how to find the balance between accessibility and availability and reliability. And in the end, we're not talking about G protein coupled receptors only. You can see different autoantibodies found by different groups in different constellations that are in excess compared with the background population. And you can see a lot of signals, autoimmune signals, among POTS patients. You can see the whole list. And quite often, it depends on which group has access to which set of tests. They run the tests and they find something. They say, oh, it must be that. Of course, this is not fair, again, to patients. But it means that these patients are not immunologically in balance, normal. So, finally, I would like you to take home these messages. So there are multiple signals from different centers now that POTS patients produce excess autoantibodies against cardiovascular receptors. You know which they are now, I hope so. And these autoantibodies, or the overstimulation or blockade, produces effects that are a plausible explanation of the syndrome. And in the end, we lack data which immunological immunomodulation or immunological intervention could be effective in POTS, except for some anecdotal reports. Interventional studies are really needed now. Finally, I would like to thank all these people, and especially Professor Kem, who couldn't be here. He's very sick now, 84 years old actually, and who started all this. And so I'm really thankful to him. And we have his legacy, and we have to push this forward now and to find a solution for these poor patients. So thank you very much for your attention. And
what's the stimulus for the autoantibody? What's triggering?
it was a tricky question, a good question. We're trying to figure out what is on the structure in the viral capsid, or where is the trigger? You know, where is the exactly? So we don't know. It used to be like that the body just identifies some intruder, and then the intruder is quite similar to something which is in the body. But the body used to recognize intruder by HLA system. So this is like your passport. So you're standing here, and the antibody is coming, approaching you, and just show me your passport. So you're showing HLA, A, B, D, and so on, C. Oh, you say you're good, you can go. But then if you just lost your A, B, or something genetically, then if you, for some reason, lose another part of your passport, then what does the antibody do? Exactly, it's what's happening. If you're too big, then it tries to keep you, hold you in some way. And it can produce effects like cardiovascular effects in this case. This is our best guess now. We're still guessing, but we have a lot of proof as well. Did I answer your question? Partially, I know. We don't have all the answers yet. I'm sorry. Working on it.